Okay, thank you. Uh, Myself, Dr. Sadhana Kulkarni. I am Professor of Emergency Medicine, uh, Aurangabad. It's my proud privilege to tell you that I belong to the place where Ajanta and Ellora caves are there, and this is one of the seven wonders in India. I bring greetings from Mahatma Gandhi Mission Medical College and Hospital, Aurangabad. There are no conflicts of interest to declare. In next 20 minutes, we will be discussing about why the obstetrician should know about postspinal headache, what is its pathophysiology, clinical picture, and management, and how we should follow the patients after postspinal headache. And this is with special considerations to the obstetric patients. As all of you are aware that spinal anesthesia is very commonly used regional block because of its potential advantages like profound analgesia, muscle relaxation, no airway instrumentation, lack of polypharmacy, which is a major advantage to the newborn. PSH is common in obstetric patients because majority of the cesarean sections are carried out under spinal anesthesia, and the incidence of postspinal headache is 0.3 to 11% after spinal anesthesia, and that after accidental dural puncture is about 25 to 40% because the size of the epidural needle is larger, that is 18 gauge as against 27 gauge for spinal anesthesia. According to International Headache Society, postspinal headache is headache because of the low CSF pressure occurring within 5 days of lumbar puncture. In 2013, the postural component was there, that is the headache which starts within 15 minutes after sitting and is relieved after lying down within 15 minutes. But that component is not included in 2018, maybe because 5% of the patients may not have postural relationship. Majority of the patients they develop uh, PSH within 48 hours, but it could be delayed by up to weeks or even months. PSH is a troublesome problem for the puerperal mothers as the feeding of the baby is affected, and there is dissatisfaction and depression in the mothers. It may prolong hospital stay or even need readmission. Expedited discharge of mother or delayed onset of PSH in women may not capture all the mothers developing PSH after hospital discharge, and this is a major problem for diagnosis as well as delay in the treatment. Why the obstetrician should know about PSH? 30% of the mothers have headache in the postpartum period due to various causes, and obstetrician should suspect PSH and inform the patient to the anesthesiologist. The mother after discharge might first report to the obstetrician or general practitioner. A pilot study at Aurangabad revealed that nearly 70% of the obstetricians they manage the PSH without referring the patient to the anesthesiologist, and they have got very limited knowledge about PSH. Misdiagnosis of PSH or its sequelae can be life threatening and may invite medico legal litigations that the obstetrician should remember. Report on confidential inquiries of maternal deaths in UK revealed that two maternal mortalities were there because of the delay in the diagnosis of subdural hematoma and cerebral venous thrombosis, which was associated with postspinal headache. Timely diagnosis of similar complications in our study saved both the mothers when the mothers were admitted to the hospital in time. Exact mechanism of postspinal headache is not known. Leakage of the CSF leads to reduction in the intracranial CSF pressure and traction on the pain sensitive intracranial tension, which results in headache, which is more in upright position. The problem is when the dural puncture is not recognized during extradural block, and patient has got headache. Mostly the diagnosis clinically by exclusion and postural relationship of the headache that confirms the diagnosis. We can carry out a simple sitting epigastric pressure test by applying pressure on the epigastrium uh, for 15 to 30 seconds. The pain relief is seen, and after releasing the pressure, the headache recurs. This confirms the diagnosis. But 5% of the patients may not have any postural relationship. In such cases, if the epidural catheter is in place, aspiration of CSF from the epidural catheter confirms the diagnosis. 30% of the mothers during puerperium may have a headache, but only 4.7% is attributed to PSH. So the obstetrician should know about what is the clinical presentation of PSH. It's mostly bilateral dull and initially starts in the frontal or occipital region and may spread to rest of the region. Pain is exacerbated by head movements, coughing or sneezing. Other associated symptoms like neck stiffness, pain in cervical thoracic region, nausea, vomiting or vertigo, diplopia or auditory disturbances may be seen because of the traction on the cranial nerves and the C1, C2, C3 cervical nerves. These are the various causes of the headache. Apart from migraine and tension headache, which are primary headaches, rest of the headaches are associated with the medical conditions, and the obstetrician should be well aware of them. Imaging is not needed for diagnosis of PSH, but it is to evaluate alternative diagnosis. And we can remember the mnemonic scan me for imaging, sudden onset of the headache, seizures, headache not related with the posture, altered mental status, neurological deficit, medications not relieving the headache, elevated blood pressure, and headache in immunocompromised patients and with fever needs special attention. Obstetrician should be aware of the red flags like subdural hematoma, posterior reversible encephalopathy syndrome, that is PRES, cerebral venous thrombosis, and intracranial hemorrhage. Even though these complications are rare, but they are life-threatening. Treatment needed is different from PSH because in cerebral venous thrombosis, the patient will need anticoagulants, while in the PRES syndrome, patient may need mannitol. On the other hand, in PSH, we give fluids for the headache. If MRI is taken and it is postspinal headache, you will find that there is enhancement of the meninges in MRI and the venous sinuses are dilated. The cerebellum is pushed caudally because of the traction. This is cerebral venous thrombosis, and this is after treatment. This is the epidural hematoma. This is a patient MRI showing the PRES syndrome. The edema is more pronounced in the posterior region of the cerebrum. We can grade the severity depending upon how much is the interference with the daily activities. In moderate and severe headache, the daily activities will be hampered to a larger extent and they do not respond to the drugs. There is no universal practice guideline for diagnosis as well as treatment. Currently, multi-society practice guidelines are used and they help to reduce the hospital stay as well as morbidity and mortality. We can have our own guidelines based on this one. There are no definitive measures for prophylaxis. The anesthesiologists use small sized non-cutting needles for spinal anesthesia, but the problem with epidural anesthesia remains because the size is 16 gauge or 18 gauge and the accidental dural puncture uh, problem still remains. There is no support for recommending prophylactic bed rest and aggressive fluids. Bed rest is generally useful to treat PSH for symptomatic pain relief, but prolonged bed rest is not advised. Intravenous fluid should be used only if the oral hydration is affected. Paracetamol, NSAIDs, they help to relieve the pain. Opioids can be used only for short term, 2 to 3 days. At some places, caffeine is used, but it should not be used in patients having seizure disorders or pregnancy-induced hypertension or patients having history of supraventricular tachyarrhythmias. Available incidence does not support routine use of drugs, like hydrocortisone, theophylline, or cosintropin, as well as gabapentin. When the headache doesn't respond to drugs, epidural blood patch is the only definitive treatment. Patients 20 ml blood is drawn under aseptic precautions and is injected in the epidural space. The efficacy is 33 to 91%. Epidural blood patch stops the further release of CSF, and it pushes the CSF uh, towards the cephalad region, and thus the traction is reduced. Uh, if the headache is partially relieved, we can repeat epidural blood patch after 24 hours. And epidural blood patch is contraindicated when the patient is on antithrombotic drugs if the platelet count is less than 70,000 and the patient is having septicemia uh, or malignancy. In such cases, for septicemia and malignancy, we can use fibrin glue instead of epidural blood patch. But the problem of the anaphylactic uh, reaction, so also aseptic meningitis should be kept in mind. Other measures like sphenopalatine ganglion block transnasally and greater occipital nerve blocks can be used. All these modalities should be known to the obstetrician because they have to advise the patient and also solve their difficulties. The long-term complications because of PSH can be chronic headache, depression, or cranial nerve palsy or cerebral venous thrombosis. There is no evidence that epidural blood patch reduces these chronic complications. The follow-up of the patients is very essential with the either obstetrician or the primary care physician, and they should be informed regarding PSH management and the red flags by the anesthesiologist, and it is anesthesiologist's responsibility. Follow-up should be continued till the headache is completely resolved. Patient should be given adequate information at the time of discharge that if the headache recurs or is accompanied with the fever or in pain in the neck or not relieved by the drugs or the patient is having altered sensorium immediately should refer should approach the obstetrician or the anesthesiologist. The challenges which are faced during management because the exact etiology is not known and the problem is persistent after the accidental dural puncture with the epidural as the size of needle cannot be reduced. Expedited discharge of the mother and the delayed onset of PSH is problematic for the diagnosis as well as treatment. Diagnosis may be difficult if there is additional associated condition like PIH accompanied with PSH, then diagnosis may be difficult. To summarize, most of the patients of PSH of mild to moderate severity will respond to the analgesics, but epidural blood patch is the only proven treatment for severe headaches. Consensus practice guidelines from Multi Society International Working Group and Obstetric Anesthetist Association provide structured evidence-based guidelines. These guidelines help to reduce the mortality and morbidity and medico-legal problems. We must incorporate the possibility of PSH in the informed consent. High index of suspicion should be there for red flags. There should be institutional policy for diagnosis, management, and follow-up of such patients. The referral letter should inform regarding PSH and its complications to obstetrician and family physician. Obstetrician may be liable for the medico-legal litigation if they do not refer the patient to the anesthesiologist and neurologist in time. So my take-home message is current approaches towards prevention and diagnosis and treatment of management of complications of PSH are not uniform globally. Clinical research is needed to find out the exact mechanism of headache and uh, clinical methods for the diagnosis and the efficacy of the treatment modalities. Institutional policy should be framed for PSH. Awareness amongst obstetricians and general practitioners and patients regarding PSH is. These are my references. Thank you so much.